Welcome to the Medical Minute podcast. I'm Anne Connell, a Melbourne-based GP and skin cancer doctor.
And I'm Moz Calafella, also a Melbourne-based GP and skin cancer doctor. We've got a very exciting episode today, Dr. Anne. What are we talking about?
Well, it's the month of March and traditionally the month where we focus on fundraising for melanoma research. So we thought we would take a walk through some of the exciting things that largely Australian research has uncovered in the field of melanoma. And as always, I'll remind you that a podcast can't replace individual advice with your own healthcare practitioner. Dr. Moz.
Excellent. So first cab off the rank is something called Melaseq, which is a very exciting new Australian piece of innovation. Could you tell us a bit more about Melaseq, Dr. Anne?
Yeah, so Melaseq, as you said, Australian owned and developed technology. And what it does is super clever. It looks for the genetic fingerprint of invasive melanoma, either in your bloodstream or in a piece of tissue. I think we'll probably talk about the blood test first.
So I think this is a question that we get all the time, isn't it, Dr. Anne? So lots of people are used to getting a prostate blood test and a cholesterol blood test and a sugar blood test. And so it's not unusual for people to say, is there a melanoma blood test? And basically, almost always the answer is no, but we might be moving into a world where the answer is yes. So what does the genetic fingerprint look for, Dr. Anne?
So the blood test, we should say first off, that has not yet been approved in this country. The tissue test has, but we're just waiting to get the go-ahead from NATA on the blood test. So it looks for the genetic fingerprint of invasive melanoma in your bloodstream. And I guess we have to therefore explain what an invasive melanoma is. Shall you take that, Dr. Moz?
So essentially, when we look at melanomas, we're looking at how thick they are to decide how nasty they're going to be. So if something's a really thin melanoma, then we sort of think that you're going to have a better outcome. If something's a very thick melanoma, we're really worried that the risk of a bad outcome is more likely, and we usually offer more treatments beyond just surgery for the thicker melanomas. So sometimes, though, working out whether it's thick or thin and how this test sort of comes into play a little bit is really difficult because someone at the lab has to look at it under a microscope and sort of measure how many cells they think it's, going from top to bottom. So it can be really, really tough. So the blood test and the tissue test, they're slightly different sides of the same coin. And so they might have different use cases, but they're both very, very exciting, aren't they? So where do we think the blood test is going to come in, Dr. Anne?
Yeah. So the blood test probably is going to be used for high-risk people who either have already made lots of melanomas or are high-risk, perhaps because of genetic inheritance or family history. And the thought is that people will have a blood test perhaps once a year to see if there's any evidence of an invasive melanoma somewhere on their body. And that, of course, is then you need someone like us, because you then have to get your skin checked top to toe to see where the cheeky little melanoma is. So that would be the first instance. People who are high risk might consider having a blood test once a year. The second sort of possible use for that would be in seeing if the treatment given for your melanoma has actually worked. Because the treatment given is usually wide local excision. We take it out with 1 centimetre in every direction and 1 centimetre deep. And in a small study, it can show that the blood test numbers actually fall quite quickly if the melanoma is cleared. So if your particular blood test markers don't fall after you've had your wide local excision, then that would make us think, hang on, have we cleared this melanoma? Has it unfortunately spread somewhere else? So it would be a really early indicator that some other extra treatment was needed.
And just to be crystal clear, this is Dr. Anne and Dr. Moz postulating about how we might best use it, because actually there isn't enough research yet for us to work out where it's best placed to help us in clinical land. But it's really exciting research, and I think that it has so much potential to really be quite common in the skin cancer world, isn't it, Dr. Anne?
It is indeed. I think it will be quite costly to begin with, although we may move to a point in the future where Medicare fund it once we've worked out where it fits in. But it's super exciting. So that's the blood test, not yet available, but I think the expectation is this year sometime.
I think one thing that I think you and I both think in our heads, and we've definitely talked about off camera, but I think one of the things that we're sort of cautiously waiting for with the melanoma blood test is if we use it in everybody. And like you sort of said, you need to come and see one of us. The reason that you would need to see one of us is there isn't a good way to CT scan you or MRI you or do whatever to find this melanoma. So if the melanoma blood test comes up positive and you don't have any weird moles, we got to work out where this melanoma is. And so I think that'll be very interesting to see how they sort of fine tune its use case a little bit more.
Yeah, because it'll be a sort of a high stakes game of where's Wally, and it'll be quite worrying. And I think, again, when we talked off air about this, you sort of said, so if we know there's an issue with your gallbladder, we can just take your gallbladder out. Or similarly, if you get abnormal cells on the cervix, then we can take a large chunk of your cervix away.
Yep.
Not so easy with your skin. You kind of need most of that.
Yeah. Really, really hard for us to de-skin you. It's not a common procedure. Yeah.
No.
Excellent. Let's talk tissue test.
So the tissue test has very recently been approved, not funded by Medicare, and it is not cheap, maybe about $950. But where that's going to fit in is where your pathologist is having a really difficult time deciding whether something is a melanoma or not a melanoma, which may come as a surprise to the audience.
Yeah, absolutely. And we sort of hinted at this when we were talking about the thickness of the melanomas, but there isn't some magic computer at the other end that's just spitting out a number. That we are relying on skilled colleagues who see a lot of skin cancer work to be able to very accurately look at these slides and tell us that they think it's X, Y, or Z thickness. And both you and I, Dr. Ann, have had plenty of cases where there's been confusion over whether it's a melanoma or confusion over how thick the melanoma is. And that's kind of where this blood test would be really excellent, isn't it, Dr. Ann?
Yeah. So the tissue test, So currently the tissue, that's okay.
Yeah.
The tissue test can only tell for sure it's a melanoma if it's a thick melanoma. So currently it can't tell the difference between a mole and a thin melanoma, because mole and thin melanomas will get the same result on the tissue test, whereas a thick melanomas that would be greater than 1 millimeter thick will be picked up by the tissue test. So again, still trying to work out where it fits in, but all advances are useful, and it's then playing around and working out how best to use them.
At $1,000, I don't think it's going to be routinely used on everyone.
No.
But probably at $50, you might find that it ends up being used on everyone. And I think even at $1,000, it still has a lot of clinical utility. I think I haven't spent a lot of time thinking about this, but I can think of at least 4 or 5 cases in the last 2 years where it would have been probably invaluable for the patient to have that information, because there was huge disagreement between really smart pathologists about how thick their melanoma was. And so if we had another additional objective measure where we could say, well, actually the genetic fingerprint is more in keeping with a really thick melanoma, that'd be really helpful for the patient. I think that'd be really, really good.
Yeah, because we're back to what you said already, that ultimately what you're getting is a professional expert opinion from the pathologist. And when they've looked at pigmented lesions, specifically lesions where we're trying to decide, is it a mole, is it a melanoma? If you have 4 pathologists look at the same lesion, a tricky lesion, 3 of them will say one thing and 1 will say the other. There's only 75% concordance. So having, as you say, an objective test might help make up the minds.
Absolutely.
That's
absolutely.
good.
And I think before we move on to the next thing, I think this is probably the thing that we're most excited about, primarily because out of the things that we're going to talk about today, this is the thing that we're probably going to get our juicy hands on the quickest and will end up sort of being incorporated in our practice the fastest, isn't it?
Yeah. So that's the Melaseq test. Very exciting. We will tell you more when we know more about it. I think next, we're going to talk about a couple of research papers, again, largely Australian. And the reasons for that are quite sad, because we are world leaders when it comes to numbers of melanomas. So lots of subjects to study, yeah?
Yeah, absolutely. So pretty much nobody does it like us other than the Kiwis.
Yeah. I think the sad statistics are that is it something like every 6 hours an Australian dies of melanoma? And there's a new diagnosis. Is it every 30 minutes? Something like that?
Every 30 minutes, that's right. So that's pretty quick. So in the time that we've finished our podcast, there'll probably be at least 2 people diagnosed, one at the start, one at the end.
Yeah. So thank goodness for researchers working tirelessly. So a study that came out just last month, which was the 7-year follow-up of the ABC trial involving our very own Professor Georgina Long, announced some very, very positive data for treatment of people where melanoma has spread to their brain. Yeah.
Yep.
So if we go back to 2010, before we had any of the fancy life-changing drugs for advanced melanoma. In 2010, if your melanoma had spread to your brain, it was a life sentence. You were told to go home, sort your affairs, and say your goodbyes, because you died within 45 months on average. It was an incredibly sad and final diagnosis with nothing we could help you with anymore. But that all changed in 2011 when we had the new cohort of treatment drugs, which were the targeted therapies and the checkpoint inhibitors. So the ABC trial is about checkpoint inhibitors for the treatment where melanoma has spread to your brain. And it actually already reported in 2018. And what it showed was that after 17 months of treatment, it was much better to use 2 of these checkpoint inhibitors together than to use one alone. And
I'm just going to highlight, you've said 17 months of treatment. So we've gone from life expectancy of 4 to 5, right? So we think it's all over in 4 to 5 months to, hey, within the study, we got to 17 months of treatment and we thought this one was a bit better, right? So already that language I'm loving. Yeah, go on.
Yeah. So we're at 17 months and showing great results by using 2 of these in combination. So of course, if you go back to 2011, we had all these amazing new drugs that trials had shown that these individually worked for advanced melanoma, but we had several new drugs and we didn't know which one to use for what, whether to use them together, whether to use them sequentially. So there have been trials ongoing to try and work out, make sense. It's a bit like, I suppose it's the Melaseq, maybe 8 to 10 years on that we had new stuff, but now we know what to do. So maybe we should pause and talk about what a checkpoint inhibitor is. Do you think our audience would have any interest?
I think a brief high-level overview of what the checkpoint inhibitors is. So I think, I think the best way to think about them, and I think I can't take credit for this analogy, this is definitely a Dr. Ann analogy, is essentially those T cells that float around the body. They're like the little assassins that kill everything that doesn't have anything to do with your body. And essentially the problem is if you've got a melanoma, it looks like you because you made it. And so when the T cells come through, they go through these like security checkpoints and they go, oh, you're okay, mate, to the melanoma. And so these checkpoint inhibitors just basically get rid of those checkpoints for these melanoma cells. So they don't offer them the opportunity to sort of do the ID check. Are you part of Moz? Are you part of AN? And so the T cells just attack them ruthlessly, which is fantastic. Really clever piece of kit.
Okay. So 2018, we knew that the drugs worked and that using 2 of them together as your first treatment was still working for a lot of people at 17 months. So we now have 7-year data from the same cohort of patients, and the results are fantastic. Yeah, 7 years on, half of these patients are still alive.
Which is, if you had said to someone in 2011, hey mate, last year your life expectancy was 4 to 5 months, we've got a new study, do you want to take part in this? And 7 years on, you are kicking goals still, you would be pretty grateful, I think, for these new medications.
Absolutely. Yeah. And so overall survival was 51%. Yeah. And progression-free survival, so their cancer hadn't advanced at all in 7 years, was 47%. So we're looking at 51% are still there, and 47% their cancer hasn't progressed, hasn't changed.
Which is amazing.
It's holding it. So it's sort of cancer as a chronic disease. That's really the territory we're moving into. It's fantastic.
Really, really amazing, isn't it? So I think that's a phenomenal piece of research by Dr. Long and her team, or Professor Long and her team.
So exciting stuff, Australian research, and very hot off the press. I think it's just been the last couple of weeks that's been announced. So very, very exciting times. So there was another study actually came out last year called the Keynote 942, and this one was also for advanced cancer, so for stage 3 or 4 cancer, but this time is when it spread to places that were not your brain. Shall we pause and talk about staging of cancer, Moz?
Yeah, absolutely. So stage 1 and 2 melanomas. Well, actually, before stage 1 and 2, we've got in situ melanomas. In situ is the fancy pants Latin way to say it's contained. And so we're talking about contained to the top layer of skin. Stage 1 and 2, it's invasive melanoma, but usually it's just wherever the melanoma is. And then stage 3 is we think that's spread to your lymph nodes, but it hasn't gone beyond that. Stage 4 is, hey, this has gone far away. And so that's, the stuff we were talking about for the last trial, it's gone to the brain. That would be a stage 4. You get a skin cancer on your finger and all of a sudden there's melanoma in your brain. That is a stage 4.
Yep. So the keynote was stage 3 and 4 cancer, but specifically not brain cancer. It was spread elsewhere because in this trial, the patients had all of their known cancer deposits cut out. They were put on one of the checkpoint inhibitors that we talked about for the previous, the ABC trial. But they were also then given a vaccine that was personalized against the genetic fingerprint of their own melanoma. And this is sounding quite a little bit like similar technology to the Melaseq that we talked about in our first section. Yeah.
And I think one thing that people so often doctors don't hear about this stuff until these research papers come out. Like there's not like some secret club where we're all hanging out and talking about this sort of stuff. So when someone comes out and says, we've created a personalized vaccine, that is like really crazy stuff. Like it really feels like science fiction, doesn't it? Like it really feels like we're working in the future. So this is mind-boggling. So someone is creating a customized drug just for Moz or just for Anne or just for Jane Doe or John Smith or whatever the case is. It's amazing. And so how did they go with these personalized vaccines, Dr. Anne?
They're great. So adding the personalized vaccine to the cutting out all of your cancer deposits and the checkpoint inhibitor therapy reduced the risk of death or recurrence by 44%. So a really, really meaningful prolongation of life. Yeah. Fantastic. Yeah.
It's really, really amazing. And I think this is really similar in tech to the mRNA stuff that we were using for the second gen COVID vaccines, like the Pfizers and the Modernas, isn't it, Dr. Anne? But rather than sort of being custom for the bug, it's custom for the human.
It is indeed. Yeah. So again, no idea what these personalized cancer vaccines will cause, but it's amazing that technology exists. And like most advances in medicine or any other field, things start off super expensive, but as the years pass, the cost comes down and they become doable on a large scale. So very, very exciting.
5 to 7 years before the sort of, non-invasive prenatal testing for pregnancy started off at, close to 10 grand and kept getting cheaper. And about 5 years later, it's dropped down to $500. So, and almost every pregnant woman now gets it. So here's hoping that these advancements sort of follow a similar route if they continue to be found helpful in further research.
Yeah, but very, very exciting. So I think the last thing we wanted to have a quick touch on, which is, I guess, not quite research, but it's artificial intelligence is coming into every aspect of life, and melanoma diagnosis is no different. Yeah.
I feel like this is a conversation I have almost on a daily or second daily basis in the consulting room ever since like ChatGPT came out. So once ChatGPT came out, everyone wants to ask about AI in skincare. So what sort of things are we currently looking at in terms of the AI being integrated in skin cancer practice, Dr. Anne?
So I think there's sort of three main areas where AI is actively being looked at to see where it can help us diagnose you more reliably or more quickly or more efficiently. So it can be used to help decide which spots on somebody's skin merit further examination with our little dermatoscope, which is our handheld skin microscope with a light thing that they can pre-screen you with a machine, and it can say, hey, that spot looks a funny size or a funny shape or funny colors. So there's that. It can also... The machine can look at the pictures that we take with a little handheld dermatoscope and give us its opinion. And that's very early infancy, that particular aspect. But it's starting to do it. It's still learning. It's a baby, but it's starting to do it. And the other probably most interesting and most researched part of it is that it can help monitor over time whether some of your spots have changed.
Yeah, sure. So we've not had this conversation off air, and so I'm going to be interested to see what your reaction is sort of live on camera. But I've noticed that the new software that we're using does actually do a pretty good job of update its AI prediction, I think pretty reasonably on the progressive images. So it might give you a really high risk reading the first time, and you as the clinician who has a bit of experience might go, well, I disagree that we need to immediately remove this, but I think it is odd and I think we should look at it again. And when you do look at it again, I think the AI updates quite nicely and reduces its risk, which I've noticed a bit in the last maybe month or two, as I'm seeing a few more patients coming through with that new software. Is that something that you've noticed?
I would agree. Obviously, the system that we're using is made by the same manufacturer as the system that we used previously. Yeah. But the version we have now is probably 8 years newer than the version we had used in the past. And certainly even at baseline, the artificial intelligence is way, way, way better than the 8 years ago version, which that's what
Yeah.
you would predict. I now look at what the DEXI score is, whereas I more or less ignored it on the previous system because it was so nonsensical. What I say to the patients is that the system rarely misses a cancer. But it calls many things cancer that are not, and that we still need it's still not as good as an expert human being, but it's getting there. You can definitely see its potential, and it tells you as soon as you click on the button, it tells you this is for research purposes only. Don't make any clinical decisions based on it. But it's fascinating to see how much that has improved over time. And you're right, when we do it takes into account the change between here and here, and sometimes it's been a scratch lesion that's bled a bit, or been ulcerated the first time, and it's maybe giving you a DEXI score of, I don't know, 6 or 7, and it thinks it's a basal cell cancer. But when you take the picture next time, it looks like a harmless barnacle. It's down at a DEXI score at 1.2. So yeah, it's fascinating. It's getting there.
And I think you sort of touched on this, but I'll ask the question that almost everyone sort of jokingly asks me: do you think we're going to be out of a job based on that AI?
No, I think the smart money is that AI will not replace skin cancer doctors anytime soon, but that doctors who work with AI will replace doctors who refuse to. So
I think I was about to say, I think it'll replace rubbish doctors. So I think if you're a doctor who's not up to mustard, you probably are going to lose your job to AI. But if you are someone who is good and you are utilizing AI to improve how good you are, I think that will be what it looks like in the future for sure. Yeah.
So it is interesting. There has been, of course, in Melbourne, a study that looked at AI assistance in interpreting these pictures. It was actually done by Monash University. It's called the Smarty Study. Don't ask me what Smarty stands for, but Smarty Study. So what they found that the AI assistance improved the pickup rate of junior doctors, but that the expert dermatoscopists in the dermatology clinics, the consultant dermatologists, were still better than the machine. But it helped junior people who were just learning. It made their ultimate diagnosis and decision more in line with what the consultant dermatologist said when they had AI assistance. So there may be a role, I'm sure there is a role for it. But the other really interesting thing about that study was that it was unexpected when they started it, but actually predictable, just knowing what human beings are like, that some patients insisted on having a biopsy because the machine had said this could be a cancer, that the dermatologist, the specialist, came in and had to look and said, no, I am not worried about this lesion, or I would suggest we monitor it. And the patient was like, no, the machine says it's high risk of a cancer and I want it off my body. And you can understand that that's human behavior, but that was an unintended consequence of the AI.
Absolutely. I think because it would be so much easier to ignore if the word cancer was not in the conversation. I think the minute that the word cancer comes up, often there is like knee-jerk reflex, fight or flight responses to that word. And I think it doesn't matter how reassuring you are, it doesn't matter how calming you are, it doesn't matter how many grey hairs you have and how many years of experience you have as a clinician. If the word cancer comes up and someone, whether it's a human or an AI, is saying, I think this is a cancer, I think human nature for a lot of people is to say, well, bloody get rid of it. I don't want to see it.
And ultimately, we are here to guide you and give you information. But if someone says to me, I want you to remove that spot, I'm not actually ever going to refuse, because our diagnosis clinically under dermatoscope, it can never be 100%. It's 100% correct. There's no guarantees in life, but that was an unintended consequence. And I think that the people who know a lot about it, I think that that's what's going to happen, is that the introduction of AI probably means that more cancers will get picked up, but actually will increase the biopsy rate because there'll be more false alarms. And I guess as a nation, as the world of human beings, we have to decide if that price is worth it. So the area where AI probably is coming along leaps and bounds and has been shown demonstrably to be good is actually in the realm of total body photography, serial total body photography. Do you want to talk a little bit about that, Moz?
So serial total body photography means that you sort of take photos of the entire body. Then there are lots of methods of doing this, and probably we'll talk about some of them because we've got some degree of excitement around, how this space is going to move in the future. And then serial total body photography just implies we took some photos in 2020, and then in 2021 we took some more photos, and then we compared the series of photos that we have from 2020 to 2021. And the AI decided that the spot on the left shoulder when you were in this position looks a little bit bigger or blacker or browner or darker or whatever the case is. It looks different compared to the previous image, and it'll highlight that to the clinician and say, hey, I think you really should pay attention to this particular mole. And so that's sort of what we're talking about when we're talking about total body photography.
And it will tell us if there's new spots as well, won't it? It will say,
yes,
hey,
absolutely.
there's a spot here that wasn't there before.
Yeah.
So it just makes it really efficient, because some patients that we're looking at have 100, 200, occasionally 300 brown spots on their body. So if we were to manually compare the pictures, that's going to take a long, long time. And our human error comes in to it, that we might not spot that something has changed in a tiny bit. But the machine reads the pictures and tells you what's changed.
Absolutely. And I think that especially for the high risk, high mole count patients, this is really where it's going to make a difference, because, I think if you're sitting there and talking about 300 moles and trying to manually compare 300 moles, that is an astronomical amount of workload. And so either it isn't going to happen, or it's going to happen at a very hefty cost to the patient. And so if we can improve that in any meaningful way, then it'll probably lead to better outcomes for the patient and at lower cost, which is fantastic.
I mean, there's a couple of caveats in that the total body photography, your two instances or two or more, your subsequent pictures have to be on the same system as the first one for the machine to be able to compare. So state of the art is when you have one that does a 360 picture of your body in a single capture, and that can usually be reliably reproduced the next time. When you have instead the more standard ones where you strike a number of different poses and turn and get more pictures, that is really difficult, because if you don't get exactly the same pose as last time, then the machine will also make errors if you're turned a few more degrees. So the 2D pictures are hard to get reliable. Serial total body photography is still helpful. But
I think there are some people that do it really well. I think it requires a high degree of dedication to making sure that those images are really good. So there are certainly some places that do that really well, but it's really hard to do well, isn't it, Dr. Anne?
It is. Yeah. But obviously state of the art, but very expensive, is when you can actually get the whole body surface done by a fancy machine in a single capture, because you just have to hold still for, I think, 2 seconds or something, and the picture is taken. So again, really exciting stuff. Currently very expensive tech. Hopefully as the years pass, the cost of that will come down to be more doable on a bigger basis.
So just to give people context, I think what we're talking about is something called the Vectra. That's the 3D thing. So that's the one that's sort of leading the charge as far as most of the research is concerned. And I think for context, I think there's about 5 in Melbourne at the moment or something like that. So there's not a high number of these. This is not something that, you can find on every street corner just yet.
No,
very
not
much
at all.
in the leading edge of things, very much like places that are really dedicated to the highest degree of total body photography. So that would be the places that that would be sort of interested in having a Vectra at this moment in time.
Yeah. So again, exciting technology, and obviously we would love to be finding your skin cancers, particularly your melanomas, before you need any of the other things that we were talking about before you need the fancy drugs for when it's spread to your brain or spread to elsewhere in the body. So it's fabulous that these things exist, but also really exciting that we're charging ahead in the early diagnosis territory as well. Yeah.
Excellent. All right. Well, I think that probably wraps up most of the things that we wanted to talk about, doesn't it, Dr. Anne? Have we left anything else out that's super important for this week?
Yeah, I think we have covered all the things, but what I might suggest this week is that if you've enjoyed this episode, we'd love you to consider making a donation to Melanoma Institute Australia for their Melanoma March, because that's what's inspired this podcast for us today, is it because this is the month for fundraising for Australian research into melanoma. We'll probably put a link in the show notes for that. But if you can afford anything at all, or your family has been touched by melanoma, that would be an amazing thing to do, and we would see that as supporting us. So thank you. Yeah,
absolutely.
And thank you, Dr. Moz. Thank you for your time.
Thank you, Dr. Anne. So I think, as always, if you've made it this far, thank you so much for lending us your ears and attention. We hope you do find it useful. And if you did, like Dr. Anne has said this week in particular, pretty please do donate to the Melanoma Institute of Australia to help give us more things to talk about in the future that are really exciting. But from a more selfish perspective, could you flick the podcast to someone that you think was really that would really benefit from having it? So I think give us a follow on the socials, find us on Instagram, find us on Facebook. And as always, if you've got any questions, we're very happy to hear them via email or through the social media channels. Thank you very much for your time, Dr. Anne. Really appreciate it as always.
No worries. See you next time. Take care.
See you next time.